Yes, ma'am, we are good to go.
Good evening, everyone. So, we have gathered here today for a very important initiative and a very new innovation in pediatric hematology and oncology. I'm Dr. Swati Bhayana, and I'm working as a consultant in the Department of Pediatric Hemo and BMT unit in Fortis Memorial Research Institute under the Fortis Institute of Blood Disorders. Today, we have gathered here for a very important topic of neuro-oncology, solving the mysteries of pediatric low-grade glioma. And for this important topic, we have a very special speaker, Dr. Purnima Navalkile. She's an associate professor in pediatrics and a specialist in pediatric neuro-oncology. She has been our to-go person for all the issues of pediatric neuro-onc. She's always been one mail, one message away, and we are really glad to connect with her. She is currently working in Children's Health Orange County, California, and is doing neuro-oncology day in and day out. Welcome, Dr. Purnima.
Hi, good evening. Thank you so much, Swati, for inviting me to this wonderful series held by Fortis Hospital. I am going to go ahead and share my screen with you, and we'll get started. Can you see it?
Yes, we can.
Thank you so much. I think we have a Q&A session at the end. Is that correct?
That's right.
Okay, so I
The
will get
stage is yours, ma'am.
Okay, I will get started and then we can, get the audience to participate and ask questions or have a discussion. Thank you.
Sure. Sure.
Okay, disclosures. I'm a speaker for Day One Biopharmaceuticals. Objectives of today's talk is discussion about pediatric low-grade glioma, specifically pathology, classification, genetic predisposition syndromes, neuroradiology, description of common tumors, management focused on targeted chemotherapy, prognosis, and late effects. So, pediatric low-grade gliomas are the most common pediatric brain tumor with incidence of around 35%. The pathology for pediatric low-grade gliomas is quite heterogeneous, challenging, and changing. So this is a basic kind of picture of a nerve cell. As you can see, there are the neuron lined with astroglial cells or astrocytes, the oligodendrocytes, which are also glial cells, and the ependymal lining, which are also glial cells. And most of the tumors actually arise from these glial cells, and they are called gliomas. And my focus today is more on the astrocytic or an oligodendrocytic type of glioma, followed by glioneuronal tumors. So, low-grade glioma pathology is classified into WHO grade 1 and grade 2. As you see on this microscopic picture, you see that the cells are sparse under this high microscopic picture, and you see few mitoses, and you do not really see any necrosis or neovascularization. As against on the right side, when you see the high-grade glioma, um, low power picture, you see tons of cells, and there are going to be lots of mitosis, lots of neovascularization, and high proliferative index. So that's the basic difference. So moving on to much kind of detailed, pathology description, there is the latest 2021 WHO classification of CNS tumors, which change the diagnosis from just basic pathology diagnosis of CNS tumors to layered and integrated diagnosis, which involve not just the morphological information about the tumor, but also the molecular features. So the PLGGs are distinct from the adult counterpart, both molecularly and clinically. And this is a work in progress, the classification as well as the molecular information. The prognostic implication of the molecular or epigenetic features is still not known, and we are working towards it. And how to use this molecular information to stratify the disease in clinical trials is also being worked on. So this is one of the tables which is part of the 2021 WHO classification, where are there of some of the newly recognized tumor entities such as diffuse astrocytoma, MYB or MYBL1 altered, polymorphous low-grade neuroepithelial tumor of plenty, which of Young, which is called plenty, diffuse low-grade glioma MAPK pathway altered, or diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters. This table basically goes through all the details of what are the specific genetic or molecular characteristic of the specific tumor type. I would not run through all of that, but as you can see, IDH, MYB, FGFR, BRAF are the predominant type of alterations. So the genetics of PLGGs, the most common and important pathway that the PLGGs follow are the RAS-RAF MAPK pathway alterations, of which the most common one is the KIA 1549 BRAF gene fusion or BRAF duplication, which is gain in chromosome 7q34, which is seen in 90% of pilocytic astrocytoma, the most common pediatric brain tumor. There are also BRAF V600E mutations seen, and these are noted most commonly in pleomorphic xanthoastrocytomas, followed by gangliogliomas, then diffuse astrocytoma, and then pilocytic astrocytoma. Just to make a note, the BRAF fusion and mutations are typically mutually exclusive, which means they won't both co-occur in the same tumor. The other pathway which is followed is the PI3K AKT mTOR signaling pathway, which involves AKT phosphorylation, and that's associated with some aggressive type of PLGGs. FGFR1 gene mutations or duplications and fusion with TAC gene are also noted typically in pilocytic astrocytoma and sometimes in DNET. The newer entity MYBQKI gene fusion is specifically seen in angiocentric glioma. So what are the genetic predisposition syndromes in PLGG? The most common one is the neurofibromatosis involving NF1 gene on 17q11, which is a tumor suppressor gene, and it gives rise to autosomal dominant condition of NF1, and it involves the MAPK pathway too. The tuberous sclerosis is another genetic condition where the TSC1 or TSC2 gene is involved. These are also tumor suppressing genes, and they involve the mTOR pathway. As you can see here, both the pathways are kind of depicted in this picture on the right. So moving on to the radiological criterias, it has been modified very recently led by Dr. Jason Fangusaro, and a publication manuscript was published in 2020, which basically described the RAPNO criteria, which came off from the RANO criteria, and the RAPNO criteria is very specific to pediatric brain tumors, and what it entails is inclusion of pediatric tumor-related changes on the MRI scans and including or incorporating it into the criteria to describe a tumor's response. So typically we look at the tumor's volumetric response in 2 or 3 dimensions, and we base it as complete, major, or partial response, or minor, stable, and progressive disease. But they used to not take into account the pediatric, related tumor changes or into the response criteria. So this modified assessment actually really helps to look at the pediatric brain tumors and their characteristics on the MRI and use them in the assessment, especially in clinical trials. So moving on to describing specific entities, the astrocytomas. So as you see here, this is a MRI of my patient where you see a big solid cystic type of tumor in the posterior fossa, where predominantly it's the cyst, and then the peripheral enhancement is the solid portion. So pilocytic astrocytoma is the most common low-grade pediatric CNS tumor with around 30% incidence. It's called juvenile, but now we are shying away from that name. It used to be called JPA. So it involves a 0 to 14 years age group and is located in cerebellum, optic pathways, third ventricle, hypothalamus, and dorsally exophytic brainstem. The pathology is characteristically WHO grade 1, and the specific under the microscope characteristics are the Rosenthal fibers and the eosinophilic granular bodies. There is a specific pylomyxoid variant which is seen in infants and typically involves hypothalamic chiasmatic area and is categorized as WHO grade 2. The symptoms related to pilocytic astrocytoma can be quite insidious in onset because of its slow-growing nature. So the genetics hallmark for the posterior fossa pilocytic astrocytoma is the KIA 1549 BRAF gene fusion, which is seen in up to 50% patients. Outside of the posterior fossa presentation, there are various different mutations or fusions seen. The specific entity NF1 related glioma or low-grade glioma involves the optic pathway. So as you can see on this MRI scan, the optic nerves look like they are enlarged or thickened and that they are taking up the contrast. Along with you see a chiasmatic mass, which is also enhanced. So the NF1 optic pathway glioma is the most common CNS tumor seen in NF1 patients, around 15%, and typically seen in really young kids. This can be stable for years and sometimes can have spontaneous regression. The symptoms associated with this particular tumor is loss of visual acuity, proptosis, color vision defect, optic atrophy, afferent pupillary defect, and precocious puberty if it's especially involving the hypothalamic region. The diagnosis is based on MRI brain and orbits, and obviously getting ophthalmologist involved and making sure that they are able to do visual acuity. If possible, they can, if they are able to do OCT, uh, ocular coherence tomography. That's a very specialized test that is done in their clinic, and that can really help to understand the retinal nerve fiber thickness. And in they can also do visual field testing by Humphrey or Goldman visual fields, and that is typically possible in older kids who are more cooperative to the test. So the most important thing is getting the scan and getting the eye doctors do a thorough exam. So this is the specific type of tumor where you do not need the patient to undergo a biopsy in order to prove that it's a low-grade glioma. The characteristic features on the MRI and the abnormal ophthalmologic exam will suffice, and this is typically termed as grade 1 or low grade. So the treatment, surgery is only offered if there is complete visual loss with severe proptosis or hydrocephalus symptoms. So typically surgery is not the way to go. Um, Even biopsy is not necessary. Radiation therapy used to be given in the past, but it unfortunately led to a lot of neuropsychiatric, endocrine, and vascular complications for these patients. So we are shying away from it and using traditional, treatments with chemotherapy agents, as well as the newer MEK inhibitors, which are known to be very active on the MAPK pathway and known to have a very good effect on these NF1 optic gliomas. So NF1 brainstem glioma is yet another entity which is very puzzling, because when you see such kind of changes, this is a MRI sagittal view of my patient with T2 changes. As you can see, the T2 flare change is making this cervicomedullary area look kind of thicker and brighter. And if the patient is symptomatic with the brainstem glioma, then of course you'll need to start treatment. But I have seen a lot of patients, as well as there are case series out, the largest one by Dr. Ian Pollack, where they have mentioned that observation is equally feasible for this particular location in NF1 patients, because they may not have symptoms and they may not progress at all. So it's very different from looking at a patient who has DIPG or diffuse midline glioma, which is H3K27 mutation. So, just be sure about what the molecular features of a tumor are. So the other gliomas which can happen for NF1 patients are astrocytoma, ependymoma, spinal cord tumor, and the pilocytic astrocytomas are typically less aggressive as well as more responsive to treatment. And as I noted in the brainstem glioma, they can follow indolent course, which is basically not really doing much and just sitting there in that location forever. The therapy is only recommended in the brainstem glioma if there are symptoms or radiographic progression noted. Now, moving on to another genetic predisposition syndrome, the tuberous sclerosis complex, a related SIGA, which is subependymal giant cell astrocytoma. As you see in the picture, this is my patient's MRI with the left lateral ventricle showing a enhancing nodule inside of the ventricle. So that's the classic feature of a SIGA. You also sometimes see, although on this picture, MRI you don't see, but you can also see subependymal nodules, which are another characteristic defining TSC MRI. So the incidence for TSC SEGA is 15 to 20% of in TSC patients. And typically these are young patients, and the location of the tumor is intraventricular and has a solid enhancing tumors in it. It's when the tumor is resected, it's typically WHO grade 1. What brings the patient into the hospital is typically symptoms of raised ICP, which needs prompt therapy. So surgery can be curative. The only exception are cases of bilateral tumors or large tumors or really young patients. The other option is mTOR inhibitors like everolimus, which can be used for both treatment of seizures and SIGA. So next entity is diffuse astrocytoma. As you see in this picture, there are T2 flare changes on this actual MRI, as well as unfortunately crossing over of these changes to the other side across the midline. So diffuse astrocytomas are seen in 10% of older children less than 20 years of age, and typically supratentorial location or deep midline location, sometimes in cervicomedullary regions, and these are typically infiltrative when you see the MRI scan. These are considered WHO grade 1. The cerebral hemispheric tumors can have MYB1 or MYBL1 gene rearrangement, and typically seen again in supratentorial location. For the other alterations which are seen are the BRAF V600E mutation or the FGFR1 alteration. For the midline tumors, the H3K27M mutation portends a very high risk feature and for malignant transformation or poor prognosis. Older adolescents with diffuse astrocytomas can have IDH1 or IDH2 mutation. Moving on, pleomorphic xanthoastrocytoma. As you see on this MRI axial scan, you see a very T2 bright lesion, which is cortical, subcortical in location in the right temporal lobe. So pleomorphic xanthoastrocytoma, PXA, are less common. They are seen typically in older kids and have supratentorial, typically temporal lobe location. And these are peripherally located and typically partly cystic. The pathology is WHO grade 2, and the common mutations seen in PXA are BRAF V600E and CDKN2 a homozygous deletion. Now, oligodendrogliomas, quite common in adults, but not so common in pediatric age group. As you see on this MRI scan, you see a kind of T2 bright lesion, which is involving cortical subcortical region in the cerebral hemisphere on the left side. So the peak incidence, as I said, is 4 to 6 decades for adults, rarely seen in kids. And if noted, it is seen in frontal lobe white matter. The pathology is grade 2 or grade 3, and the oligodendrogliomas arise from oligodendrocyte progenitor cells, which is regulated by SHH and Wnt beta-catenin pathways. The FGFR gene duplication has sometimes been noted, and older adolescents can carry IDH1 or IDH2 gene mutation, as well as 1p19q co-deletion, third promoter mutation, and CIC or FUBP1 mutation. The lower grade tumors have chronic type of symptoms such as seizures or non-specific type of symptoms. So moving on to a category which is becoming more well-defined with the newer classification of WHO, the glioneuronal tumors, which involves ganglioglioma, DNET, neurocytoma, and DLGNT. Gangliogliomas, as you see in this picture, are typically cortical or subcortical, partly enhancing solid cystic type of tumors. And as you uh, it's typically noted in adolescent age group, and located in cerebral cortex, temporal lobe, sometimes in posterior fossa. Um, the pathology is glioneuronal tumor and low grade. And this is the most common diagnosis found in pediatric patients with chronic epilepsy syndrome. The features of being in supratentorial location, having epilepsy diagnosis, and undergoing complete resection does confer a good prognosis for these tumors. DNET, this embryoplastic neuroepithelial tumors, this MRI scan is a coronal view, and on the left temporal lobe, as you see here, just an abnormal T2 flare change, and that is the on biopsy confirmed to be a DNET. So DNET are rare and slow-growing tumors which are mostly seen in young boys. The location is temporal lobes, and the pathology is neuronal and mixed neuronal glial tumor, and it's low grade, and it is very commonly associated with cortical dysplasia. It's diagnosed in around 20% of patients who undergo surgery for chronic epilepsy. Central neurocytomas. So this is an actual view of MRI scan showing a large enhancing tumor, as you can see in the ventricle. So the median age is older, adolescent or young adults. Its location is typically ventricular system. There are sometimes extraventricular types. The pathology is typically involving neuronal cells. It can be a well-differentiated neurocytoma, or it can be a less differentiated or atypical type of neurocytoma. Plenty. The MRI here shows a subcortical lesion, which is like solid and cystic and has an enhancing component in it. Plenty, it's a new entity which was described in 2017. It's polymorphous low-grade neuroepithelial tumor of the young, and it is seen in older kids or younger adults, and location is cortically based in temporal and supratemporal, or in general supratentorial region. The radiograph describes a well circumscribed lesion with cystic tumor and calcifications on the MRI scan. Um, if an MR spectroscopy is done, it will typically show high choline, and the DWI does not show diffusion restriction, and the diffusion tensor imaging will show compression instead of disruption. The pathology is typically grade 1, and this is an oligodendroglioma like under the microscope with intense CD34 expression, and this is how plenty is defined under the microscope. The specific molecular aberration which is seen in plenty is BRAF V600E mutation and FGFR2 or 3 fusion. But these are so far not known to predict postoperative outcome. There is typically associated focal cortical dysplasia in plenty. The clinical features associated with plenty are it's epileptogenic tumor, so patients will come in with chronic epilepsy. The contrast enhancement in the tumor can be indicative of recurrence and of poor control of the seizures. The treatment is gross total resection, which can not only take care of the tumor, but also can control the seizure if epilepsy surgery is planned. DLGNT. As you see on this picture, it's a very characteristic, enhancing nodular lesion involving the supratentorium, and also involving the spine. So diffuse leptomeningeal glioneuronal tumor, DLGNT, is also a new entity which was introduced in 2016. There are two subtypes by DNA methylation clusters, MC1 and 2. It's typically seen in young boys and located in spinal or cerebellar region. On radiology, you will note the leptomeningeal enhancement or dissemination is not necessarily required, but what is typically seen is nodular cystic T2 hyperintense lesions scattered around in that location. The pathology CSF is positive in 43%. So for DLGNT, getting a CSF spinal tap is going to be important. Also noted on molecular features is loss of chromosome 1p and MAPK pathway or ERK pathway alterations. Clinically, these can act really aggressively and have poor prognosis. When the patient has high Ki67 on under the microscope, which is basically high proliferative index, more than 7%, age more than 9, raised ICP or hydrocephalus related symptoms on admission, and enhancing tumor on MRI scan, the prognosis is pretty poor, and the median overall survival is around 19 months. The treatment is so far not well defined, but early therapy can prolong survival. So intrathecal chemotherapy, radiotherapy, or drugs which can target MAPK pathway, if there is a MAPK alteration, have been, known to work for this tumor. The specific features for DLGNT1 versus 2 is the DLGNT1 is seen in younger boys compared to the DLGN2. The DLGNT1 is seen in spinal more than hemispheric location compared to DLGN2. The pathology of loss of chromosome 1p is common to both, as well as the gain of 7q34, and 19q co-deletion is most common in DLGNT1, as against the gain of chromosome 1q or 8 is more common in DLGNT2. Now, DLGNT1 is less aggressive, and 5-year overall survival, as you can see, is like 100%. But DLGNT2 is the bad actor, where the 5-year overall survival is 43%, basically behaves like a high-grade glioma. So let's move on to the PLGG management. So the PLGGs or pediatric low-grade gliomas are not benign tumors because they can recur. The 5-year progression-free survival is around 50%. They can metastasize around 5% at diagnosis, around 10% at progression. They can cause long-term neurocognitive and functional deficits, and they can transform into malignant gliomas. The 15-year risk is around 7% for grade 2. So the therapies. PLGGs need to be managed as a chronic disease by designing the therapy such that it preserves the quality of life and minimizes late effects. So what are the therapies involved? Are surgical resection, the mainstay, observation, chemotherapy, and radiation treatment. So the European group, SIOP, developed an algorithm for PLGG therapies. And as you can see, resection, can confer a very good prognosis for most of the PLGGs. And once a tumor is resected, observation is what is all needed. If the patient undergoes incomplete resection or only biopsy, then the patient can still be observed if there are no severe symptoms, and on follow-up scans, there is no progression of tumor. If the tumor related symptoms or progression is noted, then the patient has to undergo treatment right away. So the treatment for NF1 or younger patients is typically chemotherapy first. If the patient is older, and non-NF1 patients, you can opt to start with radiotherapy first. Dr. Harvey Cushing, the father of neurosurgery. So as I said, PLGG surgery is the mainstay to diagnose as well as to treat brain tumor. And of course, neurosurgical, intervention is absolutely important for hydrocephalus management by CSF diversion procedures and when it comes to neurosurgical emergencies. So the gross total resection can be curative for around 40% of PLGGs, and it can lead to more than 90% of 10 years overall survival. So that's the key. But not all patients can undergo gross total resection because of the location, as you see on the right side picture. So optic pathway, hypothalamus, biopsy is the only thing which can be offered for those locations. Brainstem, biopsy, but sometimes neurosurgeons forego even that. Deep mineralized structures, maybe just the biopsy. So safe maximum resection is desirable if gross total resection is not possible. There are studies which have shown intraoperative MRI can improve progression-free survival. As I said, biopsy may suffice for tumors in eloquent locations, and once you get the molecular information, and if the patient has targetable mutations, then chemotherapy, targetable chemotherapy can be used. If not, traditional chemotherapy can be used. So observation phase, when do you kind of utilize that? Post a gross total resection, the patient can be observed for typically I would do it anywhere between 5 to 7 years. And if the patient scan do not show any tumor progression, then I discharge the patient from my clinic. Post safe maximum resection biopsy or incidentally found tumor, if the patient is asymptomatic, you can continue to observe the patient after incidentally found tumor, or if the patient has some leftover tumor which is not causing symptoms. If the patient's tumor doesn't have high-risk molecular features or cytogenetic characteristics, then it is okay to observe the patient. If the patient has stable residual tumor on serial imaging, again, you can continue to observe. The other entity where observation is completely okay is tactile gliomas. Many a times you will see a patient coming in with hydrocephalus related symptoms and is found to have the tactile location gliomas. And these are typically small, rounded, enhancing or non-enhancing type of tumors. And as long as the neurosurgeons have managed the hydrocephalus with endoscopic third ventriculostomy, then you do not need to offer surgical resection or any further treatment. Another entity is NF1 brainstem glioma. As I mentioned previously, these patients can be observed if they are asymptomatic. So the adjuvant therapies, which can be used for PLGGs, the current criteria or indication is radiologic, which is, say, you see an increase of tumor volume of more than 25%, or new areas of involvement, or new lesions appearance, or increase in the size of lesions. Neurological symptoms like diencephalic syndrome, focal neurological deficit because of tumor growth, drug-resistant seizures because of tumor growth, or raised ICP-related symptoms, or symptomatic tumors or metastatic disease. Infants, when you see the infants below age of 12 months with chiasmatic hypothalamic, specifically tumors, you should opt for adjuvant treatment. Ophthalmologic symptoms such as vision loss or visual deficit, or reduction in the visual field, nystagmus, which is impairing, or any visual loss in the second eye when the first eye is already blind. Dr. Sidney Farber, the father of modern chemotherapy. So PLGG chemotherapy, this is what my practice involves, giving chemotherapy to patients with PLGG. It's a preferred adjuvant therapy in younger patients or younger kids. It may lead to tumor volume reduction or at least stabilization. The 3-year progression-free survival with chemotherapy alone after surgery is 50 to 80%. The standard intravenous forms of chemotherapy regimens are the COG 9952, regimen A, carboplatin and vincristine, followed by COG 9952 regimen B, the TPCV regimen involving thioguanine, procarbazine, lomustine, and vincristine. And it is typically avoided. This particular regimen is typically avoided in NF1 patients because of that risk of secondary malignancy, and that's pretty low. The second or third line treatment is carboplatin monthly for up to a year, vinblastine weekly for up to a year, and bevacizumab with irinotecan every 2 weeks for over a year. So this is a table which describes the most common forms of chemotherapy and for specific tumor locations. And as you can see, let's focus on the progression-free survival for these patients. What chemotherapy does is basically improves the progression-free survival for the patient from anywhere from 50 to 80%. Now, as you can see, patients who have NF1 have much better response to chemotherapy compared to those who don't have NF1. So NF1 tumors are very chemosensitive. The PLGG targeted treatments involve MEK inhibitors such as selumetinib, trametinib, and binimetinib, BRAF inhibitors such as vemurafenib and dabrafenib, pan-RAF inhibitors such as tovorafenib, ERK inhibitors alrexitinib, and mTOR inhibitors such as everolimus and samotolizib. So there are a list or bunch of small molecular inhibitors which can be used for targeted treatment for PLGGs. And I won't go through all of these, but as you can see, based on the type of molecular abnormality, fusion, or mutation, you can use specific type of oral targeted agents. Also, there is vaccine trial currently active for PLGGs, but it's very much restricted to the HLA-A2 subtype in the blood. So the PLGG's targeted chemotherapy trials are offered in the US through specific consortia. So the Children's Oncology Group is the largest consortium, and it has typically offered the standard of care type of treatment. And when it comes to the targeted treatment, it's typically has offered it in the phase 1 format for recurrent relapse type of tumors. It's specifically called Pediatric Match Trial, and that's directed towards patients who have recurrent relapse tumors, and it's a phase 2 trial. And currently the drugs which are offered are larotrectinib, erdafitinib, samotolizumab, and rexitinib. The Pediatric Brain Tumor Consortium also has quite a bit of clinical trials which are open, and the PNOC, Pediatric Neuro-Oncology Consortium, is currently the most active consortium, where they have trials which are being open for both high-grade and low-grade gliomas, less common for the pediatric low-grade gliomas, but mostly focused on the high-grade type of tumors. And of course, there are multi-institutional trials, across the country, as well as international trials where targeted chemotherapies are being tested. So giving some brief overview on some of the targeted treatments, I won't go into the details, but as you can see here, selumetinib was tested in pediatric patients with BRAF aberrations and in NF1 patients with recurrent refractory of progressive low-grade glioma in a phase 2 trial. And as you can see, with the use of selumetinib, the progression-free survival was quite good, and especially in the BRAF fusion category compared to the mutation category, and a dose of 25 milligram per meter square per dose BID for up to 2 years was given on this trial, and partial response was seen in the patients. Trametinib has also been tested for recurrent relapsed low-grade glioma by the Canadian group led by Dr. Eric Buffet, and a specific expansion cohort dose was tested, and either partial response or stable disease was seen, and they are doing a phase 2 trial. And as you can see on the right side, the multi-institutional review of use of trametinib does show uh, a partial to stable response in patients. The day 101, which is TAC 580, current now labeled as tovorafenib, was initially tested in a phase 1 study in uh, children and young adults with recurrent or progressive low-grade gliomas by Dr. Karen Wright and a group at Boston Children's. And this was based on their basic science research, which showed the activity in PLGG cell lines and showed that this oral agent had excellent CNS penetration. And in the patients that they tested out, most of them had the BRAF fusion. The drug was given once weekly by mouth, and they gave it beyond 33 cycles and saw quite a good response with almost mm, all the patients having either partial or stable disease. So they moved on to a phase 2 trial, which was led by Dr. Lindsay Kilburn, and this has been recently published, where 61% of previously treated patients, either treated with IV chemotherapy or an oral agent, oral chemotherapy, were included on this phase 2 study of tovorafenib or day 101. So many of these patients had seen another oral chemotherapy agent like a selumetinib or a dabrafenib, and they failed that drug or they failed the IV chemotherapy, and then they were allowed to be on the phase 2 trial for recurrent or progressive low-grade glioma. They had 77 patients on study arm, and then 60 were added on an extension arm once the study was completed. The dosing that was reached as per their phase 2 study report was 420 milligram per meter square, which was given once orally every week. And the overall response rate was 51%, which was noted around 13.8 months. And the time to respond for tovorafenib was 5.3 months. The adverse effects which were noted was hair color change in many patients, elevated CPK, which was not clinically significant, and anemia in 50% patients. There were grade 3 adverse events, which were also noted in up to 42% patients, and there were 9 patients or 7% who had adverse event where the tovorafenib was stopped. Now moving on to some of
Dr.
the
Purnima, sorry for the glitch. Can we just wrap it off? I'm already flooded with questions from the audience.
Oh, okay, that's great. I think that's sorry about that. So let me give me a few more minutes and I will wrap it up. Okay,
Sure.
hopefully people will still stay along. Okay, so vemurafenib has been tested out and a dose was found, and it's a good drug to be given for recurrent refractory type of tumors where there is BRAF V600E mutation noted. Sorry, I'm trying to. Okay. Dabrafenib has been tested. It has a slightly better CNS penetration than vemurafenib for BRAF V600E mutant tumors. For those patients with the BRAF V600E tumors, as you see, treatment with dabrafenib versus vemurafenib um, was tested out by Dr. Nobre's group, and they found rapid response around 4 months and sustained response up to 5 years. But discontinuation of a oral chemotherapy agent did lead to rebounds of progression and re-challenge, like giving the drug back, starting the drug back, did lead to control of the tumor in 90% patients. Uh, uh, Dabrafenib with trametinib treatment has been used as a combinatorial treatment for the BRAF V600E tumors. Everolimus has been used for mTOR pathway mutations or TSC1 or 2 mutations. So, most important slide I want to focus on is this one, where we need to be very cautious of targeted chemotherapy. It's a work in progress. Molecular testing has not yet streamlined across all the pathology labs in the nation, and I'm talking just about the US. So, across the world, I think we don't even have a consensus on what testing to do, when and where to send it. So what does more targets through newer classifications mean? Do they mean more agents? We don't know, right? Because sorafenib, case in point, is a multikinase inhibitor which was used for BRAF mutation, and it led to paradoxical activation of ERK pathway, and it actually caused tumor progression. The trial had to be stopped. Truly targeted approach really means that you are giving it only in the CNS. What does that mean? Could you use intraarterial injections, or could you use Omaya injections, or could you use certain types of nanoparticles, so which go and just home in into the CNS system? The targeted treatment still need to have synergy with irradiation, and we do not know the combination effects yet. The duration of targeted treatments is yet unknown. So far, we have only been doing it for a year, 2 years, if it's tolerable, more than that. There is always a concern for rebound tumor recurrence if a targeted treatment is stopped. And the late effects, especially oncofertility effects, are not known. So I will move on to proton radiation very quickly. Radiotherapy does have better progression-free survival compared to chemotherapy alone. I do want to emphasize on that. And 50% of these tumors can show 25% volume reduction. SRS, which is radiosurgery, can actually lead to 5-year progression-free survival more than 80%. But the toxicities also are equally concerning, right? Because we are talking about a chronic disease, so the patients and the families have to deal with the toxicities from this, not only the tumor but also from the treatment. So it increases with increased volume of radiation and dose of radiation. There are acute onset, delayed onset, and late onset toxicities, and the late onset are the one which can be debilitating. um, this was a St. Jude article or publication which basically focused on the overall survival risk in high-risk PLGG group, where the radiation treatment given as first line really led to improved survival. And in general, PLGG prognosis is excellent if it's gross total resection, and 10-year progression-free survival with the use of a chemotherapy or radiation therapy does improve the survival to more than 70%, and overall is still pretty high. And the prognosis of PLGG is dependent upon certain things like age, location, pathologic grade, very importantly, molecular feature of the tumor, and then extent of resection, as well as what therapy is used after resection. There are quite a bit of late effects related to chemotherapy, and late effects related to surgery and radiation therapy. So in summary, PLGGs are a heterogeneous group of tumors, and advances in PLGG molecular pathology and genetics needs to be streamlined for practical application across all institutions around the world. Given the indolent nature of PLGG, preserving the quality of life plays a key role in formulating its long-term management. Safe maximum tumor resection remains a mainstay of PLGG therapy. Targeted chemotherapy used in clinical trials shows great promise in improving progression-free survival. Functional outcomes from PLGG therapy needs to be included as endpoints, and it's happening. It's being incorporated in newer trials, and late effects of neurotherapy will need to be monitored closely. Thank you so much, and these are my references.
And thank you so much. I knew that was like a vast topic to be covered, but we got the gist of it, and I know you touched on the important points. I'll just flood you with questions now. I have queries that for grade 1 low grade glioma, once you start them on antiepileptics, and if they have undergone a complete surgical resection, how long do you recommend antiepileptics post tumor excision?
Thank you, Swati. This is a great question. Unfortunately, I don't manage anti-epileptics. We have neurologists who focus on that, but I have seen typically neurosurgeons start a patient on anti-epileptics post-surgery and keep it on for up to 3 months. I don't exactly know the rationale for it, but I think working along with a neurologist can really help in situations like these.
Yeah, surely, because that is the thing even I want to highlight that for brain tumor management, it's always MDT. It's
Mhm.
always discussion with the other teams. Do you recommend methylation testing in all cases of low-grade gliomas?
This is a great question. Now, I do not know how many institutes within the US, within India, are part of Children's Oncology Group, but it's a international organization, and within the US we have the Children's Oncology Group. Provide molecular characterization initiative, which is basically you could just consent a patient and send any leftover tumor to Children's Oncology Group main pathology lab in Columbus, Ohio, and they will do the full testing, which is not just the pathology testing, like the basic under the microscope testing and IHC, but they will also do chromosomal microarray, they will do solid tumor fusion and methylation. So it is already included for patients where methylation is not part of the testing, which is like, say, the tumor is very little, and you have to decide as a physician what do you want to do with that little biopsy. Then you have to obviously first get the diagnosis under the microscope and with IHC, and then the next thing you can do is whole exome sequencing or some kind of a panel testing, molecular testing of the tumor. Typically you don't have enough tissue to do methylation, so uh, you will have to decide based on how much tumor is there whether you can do methylation testing or not. And methylation is important though, and it has changed the grouping of tumors. There are a lot of case reports, including some from my institution with my co-authors, where they have really focused on this fact that tumors which were previously categorized as a certain tumor, with methylation they are able to recategorize them appropriately into a different tumor path. Thank you.
Yeah, that is actually a very important test to highlight. I have a very basic doubt. Whenever we are dealing with high-grade gliomas, we know that we have to go for a spine screen or a CSF screen. But some studies and some groups also recommend for an infantile low-grade glioma, a similar screen. So, what is your practice regarding this?
That's a great question. I think I typically, for low grade gliomas in general or across all age groups, do not recommend staging workup because these tumors don't typically metastasize. That's the nature of a low grade glioma. Of course, if the patient is having symptoms related or the MRI features which are suggestive of metastatic disease at the beginning, at the diagnosis, I think it's very appropriate to go ahead and get a full workup with MRI spine and a spinal tap. Spinal tap is typically considered gold standard compared to ventricular CSF, but whatever is safe can be done at the appropriate time. Second is if the patient has recurrence of disease or progression of disease and you're concerned that there could be spinal disease, I think it's always important at recurrence or progression to get a staging workup, even if it's a low-grade glioma.
Agreed, agreed. Also, just one thing, we all know how to deal with a pilocytic astrocytoma, let's say on upfront basis. We are always in a fix when either we are dealing with a recurrent disease or
Mhm.
we are dealing with a disease where a biopsy only is the to go thing. Let's say brainstem glioma. So in a non-NF1 brainstem glioma, where I do a biopsy only and
Mhm.
prove that it is a low grade, let's say pilocytic. So do you recommend chemotherapy in that scenario?
Great question. I think, as I said, observation can be one of the options that you can choose instead of a adjuvant treatment. And observation is appropriate if the patient is asymptomatic. If this tumor is not causing symptoms, so you just have to be a bit thorough with the neuro exam or send the patient to a neurologist if you have a pediatric neurologist within your multidisciplinary team, and make sure that there is nothing which is missed either on symptoms assessment or the neurological exam. And as long as you know that the patient is asymptomatic, you can just continue to watch the brainstem glioma, especially in NF1. But if it's NF2, again, if it's incidentally noted brainstem lesion, you can continue to watch. If the patient has any subtle signs or on your watch, like, from every 3 month scan is what is typically recommended. Then you start to notice, any subtle changes, neurological changes, or even MRI scan changes, you need to jump on and go ahead and start treatment.
Okay, I agree with that point actually. 3 month scan is something we always look forward to. Whenever we are in a fix, we always let's monitor because
Mhm.
it's not a one day decision. Let's put it over time and let's see how things go. So just the last thing, the MEK inhibitors and the BRAF inhibitors, we all are very fascinated with that. And sitting in a country like India, access to these medicines and availability and cost issues always are going on in my mind whenever I prescribe them. So we do not have a lot of patients on our cadre who are taking these medicines. So our experience is based on very low scale data. Whenever you put them on these medicines, theoretically, it is said that fatigue and rashes are a very common problem. That's what we read in the theory always. So, what is your clinical experience regarding that?
It is true that I would say definitely more than 50%, so maybe up to 70% patients will have these problems. But remember, these problems are minor. They are typically grade 1, up maybe up to grade 2. The common ones seen are dry skin, eczema, which are easily treatable with topical treatments. You do not need to interrupt treatment for these. Sometimes paronychias can be annoying, but they can be treated appropriately. There are quite a bit of guidelines of using bleach baths and sometimes using antibiotics. I've had to give some patients antibiotic for super infection, skin super infection, if necessary, but it's not a common theme. A lot of patients, especially adolescent young adults, can have acneiform rash, and that can be annoying for them. Some patients can have hair fall or hair changes, which can be is part of kind of the skin issue, which can be annoying for them. But overall, I think the benefit from giving an oral treatment and letting them like attend their school, attend their college is way bigger than the minor problems. Thank you.
Totally agreed with that. Just one case that I'm struggling with right now. This is like a recurrent low-grade glioma in a TP53 setting. So, any experience or any case you have come across with such a rare thing? I know.
Yes, absolutely. I think you're mentioning definitely an extremely rare situation because when I actually skim through pediatric low-grade glioma literature, there is barely a mention of TP53 mutation in these type of tumors. It is kind of a known mutation or abnormality in adult low-grade gliomas, but not so in pediatric ones. So very much pediatric ones are distinct from adults. So we need to always remember that. And yes, the TP53 mutation, I'm not 100% sure whether it confers a poor prognosis. But when you combine TP53 mutation with, say, CDKN1, 2, 2A, 2B co-deletions, you will note that the tumor can act aggressive. Like the tumor, even though it's low grade, it can start showing progressive disease or symptoms or needing more treatments or recurrence. So I would be very careful and watching closely. If you think treatment is appropriate, you could get started, on treatment and just kind of keep on the top of this tumor.
Okay, okay. That's a very like a very good opinion from your end, because even when we are reviewing literature about TP53, we are like, this is so rare, we really don't know. But having said that, again, I want to leave one message loud and clear that low-grade gliomas and any brain tumors are all about MDTs. You have
Mhm.
to, it takes a village to manage them. So you have to
Exactly.
keep your options open, keep your discussions open, and it's not the decision is not to be done on one day. Let it go with the flow. Do a three
Exactly.
monthly scan. The patient will answer you. The patient
Yes.
needs a treatment or not. I know it's very difficult to deal with the anxiety at that hour, and even deciding yourself, like going home and not knowing whether you want to hit chemo right now or not. But that's how it is. Thank you so much, Dr. Purnima. This is like an exhaustive talk and very amazing to connect with you. Very amazing lecture.
Thank
Um,
you.
Dr. Vikas is here. Sir, any opinion from your end?
No, no, fantastic talk, Purnima, and it was so good to hear you about low grade gliomas. I think the audience would be more wiser from today onwards when they manage low grade gliomas in their practice, and then definitely will keep on troubling you in future with the clinical issues what we face in our day to day practice. Thank you very much.
Thank you, Vikas. Really appreciate your group giving me this opportunity. I do want to mention 2 points. So, Swati, make sure whenever you have something new, something interesting, please share it with the national, international community. So, do publish your case report on the TP53 mutation in PLGG because that's extremely rare. So, the way you manage the patient or you diagnose the patient would be important for everyone to know. So, sharing will always help, enlighten everyone, or make everyone aware of such entities existing. Second is, as you said, multidisciplinary management and being patient and being cautious. These are extremely important, along with like making sure that the families are with you. It's a team, and the team involves the family. You have to take them into confidence when you make the decisions, because you if you have concerns, the family won't follow up, or if the family is too anxious and wants a second opinion, make it happen for them. And that is what we always do. That way, the family knows that you are on their side, and that you're all everyone's working towards this patient's kind of management or treatment with the same goal in mind. So thank you.
Thank you so much. Good day. And thank you so much again for being with us.
Thank you. Everyone have a good
Thank you, Purnima. Thank you. Bye bye.
bye.
Aman, please close the event. Thank you.